Thanks for tuning in today. I'm Dr. Nick, the Incrementalist. Join me as I seek out the small incremental changes being applied in other industries that we can learn from and that can be applied in healthcare. Can these changes bring immediate value, but also add up to the big improvements and revolution we need in healthcare? Come along with me to explore the possibilities. My innovative guests from around the globe have used small incremental improvements to achieve their moonshot.
And today I'm delighted to be joined by Dr. Frank Veith. He is a surgeon, professor, and the author of The Medical Jungle. Frank, thanks for joining me today.
It's a pleasure to be here, Nick.
So this is a special pleasure for me. You and I have, through some of our mutual friends, we've never actually met, but certainly our courses and careers have intersected. So this is a real privilege for me, and I'm excited to have you here. If I could I ask you just to set the stage? You've had a very illustrious career, let's be clear. You've done some amazing things, but that all started, many years ago. Could you help us by sharing a little bit of how you got to that point of being a vascular surgeon and the story up to, the early stages?
Well, so many things in life are determined by luck, and I sort of fell into medicine. My mother was a nurse. I had an uncle who was a dentist, and they acquainted me with some of the rigors of general surgery at the time. And I thought it was probably much better than a legal career, which was what my father did, because I didn't want to do paperwork in the evenings. Turned out that that didn't happen at all. In academics, one ends up doing more paperwork and writing and talking and preparing talks than I would have ever realized. But I sort of fell into medicine by chance, and I fell into surgery also by chance, having witnessed a young man with a perforated ulcer as I was a medical student and came into the hospital. We made the diagnosis very quickly. He went to the operating room and was fixed. And that sort of appealed to me. And I was not really particularly turned off by some of the intellectual aspects of medicine and internal medicine, which was the other possible career. So I fell into the surgical career and liked it, and also had the good fortune to train at a couple of very good institutions and meet some mentors that guided me into a surgical career, and things went from there, sort of largely by luck and happenstance. And I ended up as a Marco Scholar, and one of my friends, Mark Weidman, got a job in the Bronx at Montefiore Hospital, and he enticed me to join him after a career in the Army and some other things. And because it was somewhat of a lesser institution, I don't like to say third rate, second rate, but lesser, in an indigent community, I had opportunities there to develop in vascular surgery, which appealed to me a lot more than other aspects of general surgery, and that seemed to work out.
So a couple of things to highlight in there. And, one of the things, I think luck always plays a part, but I also think that we make our own luck, and making ourselves available for those opportunities when they arise. As you look back, prior to that Montefiore opportunity and the work that you've done there that we're going to cover in a second, was there anything that stood out to you that really sort of provided a step that you think, had it not happened, you might have taken a different course? It sort of provided some insight or perhaps experience through that you think was really, really important to the development of your career?
Well, I always thought, in my naive nature, that if one worked hard, did what was right, that would lead to success. As it turned out, some of the malign characteristics of human nature enter the fray, and hard work and competence doesn't always pay off. You run into jealousies and other people's lust for power and stuff like that. And so it was somewhat of a rude awakening, because I'd always thought that hard work and and trying to do a good job would be the secret to success. And obviously that's not always true.
So in that regard, I think one of the things, and I certainly got this as I read through the book, which was, okay, so I mean, I think that's true. And we, perhaps most, if not all of us, come to discover that that's, part of the human nature and the course of life. But one of the things that you must have had to apply was the ability to sort of pick yourself up and say, okay, well, that's what's happening, but I'm not going to be beaten down by it. Is that a fair assessment?
Oh, absolutely. I mean, the idea of never giving up, because if you write a good paper or submit a good grant, typically it gets rejected probably for bad reasons or inappropriate reasons at first. But if you keep trying and trying and trying and revising and not giving up, very often you're rewarded with ultimate success. So the Winston Churchill aphorism of never, 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 never give up was something that I guess did guide me, and I tried to get that across to some of my younger colleagues and partners.
So you go through this sort of early training. It provided you, I think, some great opportunities, experience that you might not have had. And you arrive at an institution where, because of the nature of it, you got more opportunities. You're in vascular surgery, which, I correct me if I'm wrong, I think is still not a specialty in its own right. It's a subspecialty.
That's very correct. Ironically, and with great disappointment, although it is a specialty, it is not recognized in the United States. It's still regarded as a subspecialty. And that, of course, is one of the chapters in the book where we were very much involved in the leadership of trying to get vascular surgery recognized as a specialty, which it clearly is, and fulfills all the necessary criteria for being such. It hasn't happened for some of the noxious reasons that I mentioned, that human nature and the desire of other people to keep power and so forth has prevented us from becoming a separate specialty, with still many disadvantages to not only to us, but to the patients we care for.
Right. So here you are, you're in, at the time, a subspecialty. We haven't seen the emergence of that to date, recognizing that, as you rightly say, it is a specialty, it's just not recognized as such. But you now start down a journey doing some things that were really, I want to say, completely against the prevailing wisdom, and I use inverted quotes for that, and a couple of things I'll pick off initially was, lung transplantation was just not a thing. I mean, at the time, even heart transplantation was very new, but there was some early successes. And then limb salvage, which, as you look back, and I recall this in my career, that, we would take a limb off for fear of losing the patient to infection. You turned that around. Tell us a little bit about that story.
Well, that was sort of typical of what we were talking about. One of my thoughts in being an academic vascular surgeon and wanting to do something that was meaningful was to address problems which other people thought were either unsolvable or very difficult to solve. And that those two areas, the lung transplantation and the limb salvage, were two areas where first, they were not very popular because they were deemed impossible. And there were many difficulties, particularly with the limb salvage. The patients aren't particularly glamorous. They're usually old, sick people in the end stages of their life that are faced with losing a limb, which is basically a disastrous complication, particularly for a sick old person. And because we did not have a lot of patients when I went to Montefiore who had the glamorous diseases of vascular surgery, namely carotid disease and aortic aneurysm disease and occlusive disease of the aorta and other vessels, we started to attack an area where we had abundant patients, all faced with loss of a limb, and for which there was no really good treatment or no accepted good treatment. And so we cautiously approached that problem, using some techniques which I was lucky enough to have learned from doing AV fistula access work, semi-micro techniques on the small blood vessels. We found that, much to our surprise and delight, some of these unaccepted procedures worked. And because they worked for us, we began to do more of them, publish them. Of course, we met with a lot of resistance, hostility, and doubt, skepticism. You couldn't be right. You couldn't do these things. They never worked for us. How can they work for you? And we just persisted and kept doing it. I trained people, my trainees and partners, to do it, and we kept publishing it. And it's now become standard of care around the world.
So thinking back to that time, and the pushback, where one of the fundamentals of science is repeatability. So you were able to achieve some of this limb salvage and capabilities. Others were saying they couldn't. You're obviously facing what some would consider a wall, an insurmountable task. What was it at the time that allowed you or helped you persist and keep pushing towards this goal, which ultimately you've been proven 100% right? It's now standard of care, standard of practice.
Well, basically, I was in an institution where we had a lot of indigent patients, and I guess I got some support from the institution. I also had a lot of pushback because many of the patients would stay in the hospital a long time till we got their revascularized foot healed. And of course, that cost the institution money, which didn't make them too happy. But basically, we had enough success that we could continue to do this. It was not a particularly financially rewarding area to be in, but it was personally very rewarding to see these people come in with a gangrenous foot and walk out of the hospital. Whereas if they'd had an amputation, that would be the end of their life, because unlike a young person who can be rehabilitated with a prosthesis, old people rarely walked when they had a major amputation. So it was gratifying.
Right. So as I pick out from that, it sounds very much like, critical to that was actually the patients and the reward that you saw that helped continue to drive you to demonstrate that success to others.
Yeah, and people would come to visit us from far away. One other very fortunate thing that we had, which I can't claim credit for, is we had unusually good arteriography. So whereas other people weren't seeing the still patent vessels in the lower leg or foot, we could visualize them and do reconstructive bypasses to those vessels, which, much to our surprise, worked.
So for those of you just joining, I'm Dr. Nick, the Incrementalist. Today I'm talking to Dr. Frank Veith. He's a surgeon, professor, and author of The Medical Jungle. We were just talking about the innovations and the push that you had with both lung transplantation, limb salvage, the art of limb salvage, which, at this point is now standards of care. We see this as sort of regular practice, but at the time was not perceived as normal. But you didn't stop there. I mean, some people just stop there and say, wow, I've achieved this, but you continued on. And at this point, you're a vascular surgeon. Some of the primary challenges we see in that area is, the challenge of repair of aneurysms, something that occurs again in that older population, significant sort of pathology and morbidity and mortality. And you start down a track of doing this in a way that at the time was completely revolutionary. Tell us a little bit about that experience.
Well, I always, first of all, our limb salvage patients were always sick and old. And we early on, back probably in the late 70s and 80s, we embraced a technique of endovascular treatment of occluded arteries, which was popularized by, or really invented by, an interventional radiologist named Charlie Dotter. And he devised the technique of angioplasty, that is, endovascular approaches to occluded arteries, and then opening them with either a tapered catheter or, as later was developed, with a balloon, so-called percutaneous balloon angioplasty. And I was, at a young age, I was president of the New York Cardiovascular Society, and I invited Charlie Dotter to speak at our meeting. This was probably in the late 70s or early 80s. And he was sort of regarded as a crazy man, certainly by all surgeons. This is not possible, it can't work. And he was known as Crazy Charlie. And he came, he gave the talk at our meeting, talking about the way the angioplasty worked, like footprints in the snow to reopen an occluded artery, making the plaque like a footprint in the snow, which wasn't the way it worked at all. But everybody in the audience thought he was crazy. They were all surgeons. It was a surgical society. But I thought maybe he had something here. And because our patients were so old and sick, I asked our interventional radiologist, Seymour Sprayregan, to go out and watch this guy work and bring his techniques back so we could use them rather than doing these big, horrendous operations on these old, sick patients. And he went out there and he came back and he started doing them. And I would sit in the angio suite with him, watch the procedures, and they worked. And they worked much better than the big open abdominal aortal femoral bypasses. So we started embracing endovascular techniques. I became very good friends with a guy named Barry Katzen, who I also invited to speak. He's an interventional radiologist, world renowned, at our New York Cardiovascular Society meeting. And that launched him on his career. He talked about lysing clots with streptokinase. Again, nobody believed him. It didn't work very well, but we became good friends. He invited me to his interventional radiology meetings, and I saw what the interventional radiologists were doing. And even though I had my doubts, I said, well, maybe these things can work for us. And I actually, at that meeting, I saw a presentation by a guy named Julio Palmes, the father of stents for opening and keeping arteries open. And he presented a talk on the possibility of treating aneurysms endovascularly with a stent and a graft. And subsequently, a guy named Juan Perotti did the first endovascular aneurysm repair in Argentina. Nobody believed him. He was regarded as a pariah by all surgeons, spoiling this good open operation that we did. But we had a very sick patient that we couldn't operate on with a big threatening aneurysm. And Mike Marin and I said, what are we going to do with this patient? We can't operate on him, he's too sick. I said, let's go to Argentina and learn how to do this procedure that Juan Perotti was talking about and nobody believed. And so we got friendly with Perotti and made phone calls. And he didn't want us to come there because various reasons, but we induced him to come to the United States and do the first open endovascular aneurysm repair with us at Montefiore in 1992 by inviting him to our meeting so he could promote his technique. And it's a long story. It's been detailed in the book, but he ultimately came after much backing and filling and adversity. We talked him into coming and got permission to use the Palmes stent, a giant Palmes stent, which was necessary for us to make the graft. And that first case was dramatically successful. And the patient lived. The next day he was sitting up in a chair reading Playboy, and his aneurysm was fixed. And so we then, I and Mike Marin started a program where we made our own endovascular grafts, some for aneurysms of the aorta, some for other diseases. And unbelievably, they worked in situations that were otherwise hopeless. So we thought we would present this work at a major meeting of young vascular surgery leaders. And I got permission to present it, although that was resisted because of various reasons. And we presented this work, which was dramatically successful, and nobody believed us. My friends, all these guys who were hotshot leaders, they said we were either lying or crazy. And but we kept doing it, kept talking about it, accumulated more experience. And I was fortunate enough at the time to be president of a couple of societies, one of them being the major SVS. And I advocated telling vascular surgeons that if they don't wake up and realize that this stuff was going to work, they were going to be out of a job. That was not well received either. It was a talk on Charles Darwin and vascular surgery and how we had to evolve as a species or we would become extinct. And we were disbelieved by all the major leaders in vascular surgery for about 5 to 7 or 8 years. And then gradually people started to realize that this stuff might work. And now it's become, of course, standard of care.
Yeah, so fast forward to today, and just, for everybody listening's clarity, this is absolutely the standard of care. You would essentially approach the majority of these kind of cases because minimal intervention. I mean, this is what we call keyhole surgery, and I know I'm oversimplifying, but just for the benefits of the audience, this is, minimally invasive. And as you rightly see, I've seen it a number of times as well. It's truly astounding when you compare, the traditional surgical repair of a AAA to the repair done endovascularly. Patients, long time in ICU, and as you said, up the following day and, mobile, and at this point probably discharged. So I just incredible progress. As you think back to the course of all of this, what do you think are the learning points that people should bring out of this? What is it that we've got and you've learned over this? I mean, you've had enormous experiences pushing back against lots of resistance. What should we take away?
Well, go counter to human nature. Don't always accept the standards of the day as being the truth, and challenge current thinking. And then if what you do works, be persistent and keep at it. Don't give up, and don't get upset when you get your papers rejected or your grants rejected. Be persistent and be lucky.
Yeah, so to be clear, the luck, I agree with you. There's components of that, but it's being ready for that and being in the mindset that continues to be open to those opportunities. You continue to this day, and I think one of the legacies that you leave is obviously the mentorship and some of the people that you've influenced over the course of your career and continue to influence, and not just that, but also the delivery of the Veith Symposium, which cleverly uses your name, but I think actually stands for something within the.
Oh, it's an acronym. It has nothing to do with me.
Yeah, no, I'll believe you, but millions wouldn't. So, what do you think? What do you think is the future as you look at the potential for all of this innovation that's now taking place? I mean, we seem to have accelerated, and as I look back over the course of some of the things that you've managed to achieve, all of that seems pretty fast, but we seem to be going even faster. Where are we going now?
Well, we're going to end up using artificial intelligence, more slicker computer technology to image the body and the vascular tree without using radiation, so one doesn't get cancer from being over-radiated, lose the hair on one's arm, and so forth. So I think for vascular surgery, the sky's the limit, because new technology is opening up all sorts of new challenges. And even though the endovascular techniques work very well, they also create a whole group of new problems that have to be solved. And some of the things happening today by my younger colleagues and successors are beyond my belief. They can do things now that we never could have dreamed of doing. And part of it's because of the constructive relationship, positive relationship between industry and medicine and doctors, which has been decried by a number of universities and politicians, et cetera. There have been some abuses, but by and large, the relationship between doctors and industry is a tremendous boon to society and
Well,
patients.
so unfortunately, as we do each and every week, we've run out of time. So just remains for me to thank you. Obviously, a tremendous privilege, an opportunity for me to get to talk to you, hear a little bit about some of the history that you've managed to create and make for the benefit of medicine, vascular surgery, and far beyond. Frank, thanks for joining me today.
Well, it's been a real pleasure and a privilege for me to be with you. Thank you so much.
Thanks for joining me today. Do you have any better ideas, or have you found a small incremental change that's brought about a big improvement in your world? Let's continue the conversation on our hashtag, The Incrementalist, or share with me at Dr. Nick1 on Twitter. You can find more information about the show on our program page at healthcarenowradio.com. And tune in next time to hear my discussions with leaders and innovators from around the globe who've revolutionized their space by using small incremental improvements to achieve their moonshot. I'm Dr. Nick, the Incrementalist, and I'm starting a revolution through evolution.